This afternoon, videotape a new procedure for recording hinge axis movements with the Panadent Axi-Path II Recorder, which is a new system of axiography. And we're going to take you through from the recording, placing the clutch on the teeth, cementing it, to putting the head frame on, and then the mandibular sidearms, recording the hinge axis, and also recording the protrusive lateral border pathways and the Bennett movement. And we have a patient, Bruce Logan, who is here with us today, and he's going to be our patient. Bruce, you want to take a seat there? Now, Bruce has had orthodontic treatment and has just finished recently, so we don't know exactly what we're going to see when we mount his cast, but we will at least have some information that might help in finalizing his mouth and his occlusion. He might have to have a little restorative dentistry, he might have to have some occlusal adjustments, or he might have to have an occlusal squint, and so forth. But anyway, the procedures right now will be to record his mandibular movements along with his hinge axis. I'm going to put my glasses on like this, and you'll have to forgive me for these because I need these things when I'm locating the hinge axis. Is this angulation pretty good for you? I think what we'll probably do is tip Bruce a little bit up because I find that you can see a little better, and I'll raise my chair a little bit higher to compensate for it. Bruce, can you lay your head back just a bit like this? Is that too far back now? I'm going to tip you just a little more like that, and I think I'll stand up for this because I think you can see better if you spin. And we have a disposable clutch, and this disposable clutch is plastic. I'm going to bring it right over here to the side, and it will cover all of the teeth of the mandibular arch. But when we have a patient that has a lot of teeth, or most of their teeth, and they have a normal crown height, we cut the posterior sections off. That way we can get a larger arc of rotation for locating the hinge axis. If we have a patient that has very few teeth left, many missing teeth, let's say, or they're ground and worn down very low in the clinical crown, then we leave this clutch to its full length. In other words, we need all the retention that we can get. So I'm taking a safe-sided diamond disc. Don't try to do this with a Joe Dandy disc. It breaks too easily. And I'm going to cut the distal portion off. So I'm cutting about 1/2 inch off the distal ends of these, maybe 3/4 of an inch. We only have to cover the second bicuspid area, and we'll have plenty of retention. Now we're switching to an arbor band, and I'm going to sand the edges smooth. I'm just rounding the corners where they're sharp, taking off any of that plastic that might be irritating to the mucosa or to the gingival tissue. Another thing that we should watch at this time is to check the patient before we put this in the mouth to see if the patient has any exostosis. Because if you have an exostosis, like a lingual exostosis especially, he does have. There's some large ones. And very often in bruxating type of occlusion, that is horizontal type occlusion, where they're overstressing themselves, you'll see a lot of exostosis. Palatal, buccal, labial, wherever you see exostosis in the mouth, I will show you a patient that has an overstressed occlusion. So we want to make sure and relieve, if we have to, any areas there on the lingual that might interfere or cause pain when this clutch is put in. So we're going to be very careful when we place it in Bruce's mouth to make sure that we're not going to hurt him. Another thing in Bruce's mouth that we have to watch, he has a lingual retainer. So we'll have to be really careful when we remove that. Also, we can put a little wax in there around that to make sure that we're not going to lock into it. Does that hurt you any of this on those exostosis? It's pretty good. I think I'll grind it down just a little bit more. It's nice to have these problems on our TV because now you know what to do when you run into it. What I'm doing here is just relieving that a little bit. And another thing is to keep the clutch positioned distally as far as you can. That also will give space for the exostosis. I think we'll have room. Let's put a little wax in here now. And this is routine. The wax I'm putting in right now is routine, and it's in your instruction manuals. So always put a little strip of periphery wax, this is Surgident, from the anterior to posterior region, and that helps to get the plaster off the patient's teeth. But in addition to that, I think we'd better put some over the wires. I'll push it way back again. Is that going all right? Push it all the way down. That's important that it seats. Now if you notice, this clutch is clear, so you can see right through it, and you can see the positions of the teeth, and it's important that it seats all the way down. Otherwise you're going to lose a lot of your vertical height if your clutch is up too high, and you won't have enough room when you locate the hinge axis for opening and closing. Let's try this. Maybe just a little bit here in the brackets. Just those two. Okay, I think that probably will do it. I'll just hold there for a moment. Let me try this back in again. Brackets cause this to be out there a little bit. Just continue. So get tight yet. That doesn't hurt. Okay, good. I think we can manage that. Oh, that's all right if that comes out.
Well, just leave it right there.
Just leave it right there.
That's right.
Yeah. Okay, let's go ahead. The next step, I need a little bit to put a little wax right here in the midline to hold the discluder. Each clutch has 3 discluders that comes with it when it's manufactured. A tall, medium, and a short, and I'm just wiping just a very thin film there in the midline, and there are 2 little holes that match up with 2 little dowels in the discluder. I'm putting the shortest discluder on right now. I put it in the distal hole first, like this, push that down, like this, then I swing the anterior portion around. I'll have to get my glasses here so I can see it. All right. And then with the anterior, there it snaps in, I swing the front around and snap it down, and sometimes it takes quite a little bit of pressure. There you heard it snap together. The next step is to put the clamp on, run these screws back. Now the clamp has a bevel right here, and this bevel must go toward the patient, like this. Now the clamp is left loose, we take the mandibular crossbar, or cross rod, and push it through the holes, and we have to twist it as we push it. You'll hear it crack a little as we go. We keep pushing and twisting until we come to the knurled area where there are some score marks there on this rod, and when you get there, you can then tighten these vertical screws like this. Don't tighten them extremely hard or you might fracture the clutch. The clutch is made to be fractured later when we take it out of the mouth. But just tighten these up finger tight, and that will prevent the crossbar from rotating. All right, Olivia is going to mix. As I said, we like to have our plaster mixed very soft. It gives us working time, So it's like thick buttermilk. We're using cur number 2.
No accelerator.
With no accelerator in it right now. Actually, in our office, we do put potassium sulfate in and accelerate it quite often. Bruce, just open your teeth like this. Just relax your mouth now. Now relax it, let it settle way, way back. Okay, like this, and I'm standing directly behind the patient and relaxing his lower jaw, letting it drop way back. It's not absolutely critical, but I've let my fingers drop to the very sides, my thumbs I should say, on the edges so that I can make sure that as I look over the front that his central incisors are the midline, is right in the midline of that discluder on the clutch. I don't have him biting on this at this point. His teeth are slightly separated, and my other fingers are right under the mandible, holding it up. Slightly open just a little bit. Just keep your teeth slightly apart. That's important, and this is a critical stage, because if you move this right now while that is setting, then your clutch may come loose during your recording and you might get a faulty recording. So it's very, very important that we hold it at this point until the material has hardened. If you want to cut that camera just a little bit, we can wait here a couple of minutes. The material is hardened, and we will clean up the excess. We use cotton pliers, and we just reach in there and break off the excess. Usually you'll find it right over your last, right over the trailing edge of it, right over the molar or the bicuspid area, like this. I'll suction in just a little bit. How does it feel, Bruce? Just great. All right, relax your jaw. All right. Now slide your jaw forward, slide back, forward, back. Now I'm looking to see that he is not contacting the clutch, the posterior areas. Can I see the mirror, please? So it's important at this time that we check him out in protrusion and lateral movements. Can you move laterally from side to side, keeping in contact with the discluder? And we see no contacts of the posterior teeth. Slide forward, slide back, way back, stop, forward, back, way back, hold it. If you're in doubt, the thing to do is to take your marking ribbon and check it. It may be a little close on the left side. Open slightly, now bite, hold it, slide forward and backward, back, right and left, slowly, way to the back, hold it. Okay, now open and let's take a look. No, he's free. Anything? I'll take his sauce pack, please. Cleaning out any excess. Try to keep the head down a little bit this way, and I think they can see it better in the camera if his head is straight. Ordinarily, we have our patients tip back, and a lot of this we're doing at a 45-degree angle, or even with the patient almost horizontal. But for the photographs here, I think it's a good thing for it to be more upright. All right, now the head frame is a face bow. It actually is an ear bow. And what's been done here is we have added these graft supports to our face bow. And then we have taken the Nasion relator on the face bow, which ordinarily would be in an upright position like this, and we reversed it, turned it upside down, and then we've added one more part to this ear bow. We've added a little device here with a third point of reference right here, where you see a dimple, and that's the orbital point. In the Panadent system, it is similar to the whip mix. It's an arbitrary distance from nasion down to the orbital point, which is 7/8 of an inch in this particular instance. We are thinking about putting some more holes in here so that you could use other than 7/8 of an inch for your arbitrary reference point at the front of the face. But right now we only have the one dimple there, which represents 7/8 of an inch below the nasion. So we'll leave that right here, like this, just back up a ways. And so the only thing now that we have added to our face bow are these graft supports, and they're held with these two screws right here, and those will fit on to the old face bows that Panadent has out in the field today. And then this little part right here has to be added. Otherwise, it's just an ordinary face bow, ear bow. And we have now put the graph paper on one side like this, and we're going to put it on the other. These graph papers come on little holders like this, and they're packaged like this, and we just peel them off, and they're crack and peel type. And there's a little reference area right here, so that when we put the graph paper up there, we put it right against that, and then bring it down, and it fits right over the paper, or rather the paper fits right over the support. And the thing I do first is have the patients take the sidearms like this and go back and measure the width of the face. Just put it back there, Bruce, right up alongside your ears like that, up higher, a little higher,
Like glasses.
just like a pair of glasses, right over your ears. Okay, there, like that. Then I lock the screw up front like this, take it off, and we parallel those with the straight edge. In other words, you hold that there, Olivia. We'll turn this down so they can see it. Watch what I'm doing. I push this graft support here, push this one up so that the two vertical plates are parallel to each other after we've measured the width of the face. Now with those parallel to each other, I can tighten the screws like this, and then we'll have the patient go back, grab the sidearms like that, and put it comfortably back over your ears, and set it there just like, I forgot to tighten this a little bit. Let's just back on. We have a little screw here we're supposed to tighten to hold it. There we go. This little screw right
Happens when
here.
you don't tighten your screw.
Okay, now put it back over your ears and just hold it there, like that. Then I can, when he holds it tightly against his head, I lock just the one screw. Now he continues to hold it, and I'm going to swing the chair around so you can see what I'm doing here without the camera moving, perhaps. And just move this around here, and we stretch. Can you move your hand slightly forward out there? And what we're going to do is stretch the rubber band about one hole or two holes past its most flaccid position. And that usually will be just tight enough, like this. You just put the rubber band slightly over the ear, like that, and he can put his hands away. It is important that you pull your rubber band down below the occipital protuberance. Don't let it get up here high, otherwise it'll lift your face bow right up off the head. So keep it down low like that, and that'll keep a little light pressure on the ears, like this. All right, now I want to show you something else that we can put this around here, maybe after the distractions. You'll notice that the graph paper is quite far forward on his face. We have to cover the tragus of the ear right here. So if you can show this. Now, Dr. Wacker, we appreciate Dr. Wacker from Loma Linda making our videos for us, but if we loosen this screw right here, then we can let the entire face bow go back, and you can see it covering the tragus of the ear as I loosen this screw up here. Now, by doing that, we also, now you have to hold it there while I stretch the rubber band just a little more. But we must have those graph papers covering the tragus, because very often that's where the axis is located. So once again, I'll go through that again. What I'm doing here is loosening this screw right here and allowing the entire face bow to go in a more distal direction, and then I have to tighten my rubber band. Does that feel pretty good now? Mm-hmm. Okay, seems to be stable? Mm-hmm. Fine. Okay, let's swing it back now. The next thing we have are new sidearms. These new sidearms are somewhat different, quite different than the adjustable arms that have been available in the past. The available sidearms for locating the hinge axis in the past have had lead screws. Those are very fine threads for a screw that would run the sidearm distally in the horizontal plane, forward and back, anterior, posterior direction, with a very fine lead screw. Then there was another vertical screw on those types of sidearms where you would have a micro adjustment for vertical movement. And they were very slow in movement, so very often the person trying to locate the axis would rather fatigue, either physically or mentally, or both, trying to locate the hinge axis. With this new sidearm, it's a little bit different, and I'll try to explain it as I go along. First of all, it has a special clamp. In this special clamp, we have separate adjustments so that the arm, this rod, can be pushed forward and backward, and at any position I push it, it stops. It doesn't move beyond that point. We also have another separate adjustment, which is this screw, which has a spring on it, which will control the pressure for vertical rotation, like this. Now to set it up, we put our recording pins, our axis recording pins, into the sidearm up here, and we have a little holder for the elastic rubber band here. We have a Bennett ring right here, which is a white nylon ring. I'm going to reverse that, by the way, and turn it this direction, which it should be. And we push this Bennett ring all the way out against the retaining ring here for the rubber band, which is a light orthodontic band. We shove this pin all the way in, and then we back it up about 4 millimeters as we read it here on this little scale. You see a millimeter scale. Then we lock this screw. That's important now when you're using the system to allow yourself about 4 millimeters of space in there. Later on you'll see why you need that space. All right, the next step then, be sure that we have loosened this screw all the way. That must be totally loose, no pressure on the spring whatsoever. The other thing that you must be sure of before you start is that this set screw or lock screw is totally loose. And then we don't need your hex wrench. You don't need the hex wrench anymore. With the patient's jaw retruded, and we can push this over the cross rod like this, and we come right up to any place on the graph paper you want, just any place. And then when you get it to that point where the steel pin is touching the graph paper, then you tighten this screw like this. Tighten it almost all the way down first, and then you have to back it up just a little bit like that, and then you can control the amount of pressure that it takes to push that up or push it down. The tighter I have this screw, the more pressure it takes to push this arm up or push the arm down. Now this screw will not affect the tension that's in here on this rod going from anterior to posterior. That is totally controlled by internal springs and ball spring inside of the clamp. You can't control those. That's set at the factory. But you can control this little screw right here for this kind of rotation. All right, now we're going to put the other one on, and we do have it there. I put my hand on top of the patient's head, usually like this, when we begin to locate the axis. And I usually cup my hand like this. I was taught to do this many years ago by an pathologist. Dr. Stewart taught me how to do this. And don't grab the chin as a handle. So often, dentists grab the patient's chin and start whopping it up and down like that. And the patients can't get coordinated with my brain. His brain is on a different wavelength. So what I do is to just hold back like a rubber band against his chin like this, and I don't make a big cup, just like a little fist here, and just put his chin right here between my index finger and my thumb like this, like a football helmet. You know, they have those chin straps. Just hold back. Then I tell the patient to open and close their jaw. In other words, let the patient open and close. Open, 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 wider, open. Just get used to it. Get the patients used to doing this. In other words, he's doing it all. All I'm doing is just like a rubber band. It's just as though I was just taking my fingers, pushing down on his head here, and pushing back here to get a reciprocal force. Just like an elastic there. All right, now, I know some of you may say, you have to be careful pushing on their chin like that because you can push the condyle too far distally. Yes, that's true. And right now, I'm not locating centric relation. What I'm doing is finding the terminal hinge axis position, which may be a little bit different than true centric relation. So we don't worry about it. We'll get our centric relation in another manner. Right now, we're only interested in stopping the jaw so it doesn't move around. That is, putting it in a position where I can repeat the hinge axis movement for locating the axis. All right, now what we're doing here, open and close now, Bruce, and I think what we need to do is to swing the chair around like this so that you can actually see that graph. That's about right, there. Because what we're thinking about is a clock, the hands of the clock, and I'm going to quickly push this up here, and I want you to notice that it will be a 12 o'clock arc, open and close, open and close. We call that 12 o'clock. Well, that one isn't quite 12 o'clock. Let me come back here. Let's make it 12. Okay, like this. And you see the arcing, like that. Now, immediately, I can swing this down low like this, just instantly, and I can get a 6 o'clock arc. Okay? Now, quickly, I can move it back here and get a 3 o'clock arc, like this. Well, this is 9 o'clock, excuse me. And then I can pull it forward out here and show you a 3 o'clock. Okay, so you want to think about the hands of a clock, and that you're trying to find where the hands are, right, the center of rotation for the hands of the clock or watch. All right, let me do that again, and we'll do it once more. I'm going to move this up quickly to a high position, open and close, slow. That would be a 12 o'clock arc. I'm going to drop it down here, open. That's 6 o'clock, and I know that somewhere halfway between the 12 and 6 is probably the center of rotation. I'm now at a 3 o'clock arc, and they're getting smaller. Slow, 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 stop. And I'm going back a little bit farther, open and close gently like that. Okay, it's almost stopped arcing. Now you notice that I'm very near the distal edge of the paper. If you will back up your camera just a little bit, if you're getting too near the posterior edge of the paper, then what you do is loosen this screw right up here at the nasion relator and let those graph papers go more distally, like this. Just let the entire face bow slide back. And then relock this screw right here, and you will have moved the paper more distally, and therefore allow your stylus to be more located on the paper, where it won't be so near to the posterior edge. I'm going to tighten the, Okay, I'm going to tighten the headband one more notch on this side. Just hold it there for just a minute now, Bruce, because when I slid that back, I loosened the headband as I did that. In other words, as this goes distally, that loosens the headband. Now he feels more comfortable. All right, now we're more in the center of the graph paper. Open and close, open and close, open and close, open and close, open and close. Now, Olivia is usually doing the other side while I do this side. Open and close, open and close. Stop. Just push it up, open and close. Okay, stop right there. That's about all there is to locating the hinge axis. You just find the center where it doesn't arc anymore. And now I'll check out this side. Open and close, stop. Just hold it and tighten the screw. Okay, open and close, stop. Open and close, stop. Open and close, stop. Open and close. Open and close, gently. Open slowly. Open and close, stop. Open and close. Open and close. Stop. So by doing this way, it's very fast because I can now check out the axis, open and close. Make sure that I move all around the axis, open and close. So I'm checking in all the different directions for the 12 o'clock, 6 o'clock, 9 o'clock, and 3 o'clock position. opening, close, right there. Opening, close. And I can zero it right on down to within a 1 millimeter square. And I don't have to worry about running those lead screws, and I can prove where the axis is very, very quickly. Now, once we've located the axis like this, the next step then is to lock these clamps, because you can move it at this time. So I need the hex wrench. And what I do on that is to take the end of my thumb and press right against the steel pin that holds it on the paper there. Now watch this closely. And then I come in with the other hand while that's still touching the paper, and I gently lock this screw. And that retains the position. Now once I've locked the screw a little bit, then I can let go of it and lock the screw a little more. Now these don't have to be real tight, because there's a lot of mechanical advantage there with this little screw. So you just lock it with your fingers. You don't have to put a lot of force on that lock screw. So again, on this side then, I take my thumb, push against the end of the steel pin, come over here and gently lock the screw a little bit. Once I get it started, then I can let go of the steel pin back here and tighten this screw a little more, like that. Now that fixes it right onto the axis, so the steel pin points are right on the hinge axis, and we're ready to do our tracing. We have, and I'll step over this way, and maybe you can pan over on this to see what we're doing, but we have a little mandrel. And the mandrel looks like this, and it fits right into your handpiece. And then you can push the writing leads, which are little nylon points with the writing lead, which is nothing more than a lead pencil, in the middle. You can slide that right over it like this, and hold this at an angle of about 60 degrees to this little disc. The disc is a very fine sandpaper disc, and we can put a very, very sharp concentric point on the lead. That. And we like real sharp points because it shows the tracing and any pathology in the joint. You can see it a lot better if you have a very fine point. Now each time you take a recording, you should do this because you'll dull those points down while you're doing the recording. All right. Next step then is to withdraw. We have to loosen this little screw right here and withdraw the steel pin and slide the writing leads over the end of the steel pin. We then lock this little screw, that's the lock screw right here that holds the stylus, and we next stretch the elastics. And I like to have a pair of cotton pliers for that. So with the cotton pliers, it's easier to stretch the elastic. If you have small fingers, you can do it very well, and you ladies can do it very well because your fingers are very delicate, but with me, I'd have to take this and stretch it up over the end of that lock screw. Now we practice with the patient. And Bruce, I want you to slide your jaw forward and slide back slowly. Do everything slowly. Slide forward, now slide back. Do it a little faster, just express right there. Back, way back, stop. Now with his jaw retruded, we then let this pin up slowly. Now watch what I do. I don't just loosen that screw and let the lead snap against the graft because it might break it. So what I'm doing here is holding it and gently letting it up. Leave the screw loose so the elastic is engaged for the recording. And Olivia has done it on the other side at the same time. Now you might back away just a little bit here and see the full face. Now, Bruce, slide slowly forward. Keep your teeth together as you do it. Slide forward all the way as far as you can go, completely out. Now slide back. Slide forward all the way, completely out. Now come back and stop when you get back. And we immediately withdraw the stylus and lock it. And then I can take the elastic off. I usually do it at least 2 times. If you get a good tracing the first time and it's heavy enough, that's fine, but each time they go forward and back, you deposit more of the lead on there so you get a heavier line. Now we like to do a little bit of diagnostic work here. And what I'm trying to find out is what happens when he opens his mouth. So we don't leave the elastics on when he does this. We leave the elastics loose. We just loosen the screw here so the stylus is loose, like this. And now he's going to open his mouth slowly, open. Watch carefully, zero right in, and you see that he's riding above his protrusive pathway. Come back. But he starts out, he's right on the protrusive pathway, and slowly open, but slowly. And he's following the protrusive path. Keep going. He's still following. Now, about there, and his mouth is quite open up front here now. He is now leaving, a little wider. Now he's beginning to rise above his protrusive path, like that, and now he's about 1 millimeter above. Now come back, like this. Now go all the way back. Well, in the functional range of the first 4 millimeters, the lines are identical. And that's really the important thing. So I'm going to switch to the other side now and look at it and see what's happening over here. Open slowly, keep opening slowly, all the way, keep opening. And it translates, it falls down about 5 millimeters, and then, now go back, and then it goes above the protrusive line. So I'd like to switch this around. Just hold the camera right there, and let's just swing the chair around so you can see what's happening on the other side. Can you see that? Just swing around. It's rather interesting. You can see his protrusive line. Can you see that? All right. Now this time he's going to open his mouth. Not protrude it, but open it. Now open wider. Now watch it slowly. Open. Keep opening. There you see it going down the pathway. Stop right there. Still following. Keep opening. Now it's going above the protrusive pathway. Keep opening. There it's above it. Now go back. And there it joins the protrusive pathway, and they're one and the same when you get back to centric relation. Most healthy joints, they'll have in the functional range, the two lines will be synonymous. Now, while we have him in that position, we're going to check his lateral border pathway. This is just the opening and closing and the protrusive that we've done so far. Let's try lateral border. Now, we don't put the elastics on for this. They're loose, and so we're not going to record it on the paper. We're just going to check it. Now, slowly to your right. Slowly. Is it following the same line? Yes. Slowly. Stop. And there it begins to go a little below it. But in the functional range, if you go back, Bruce, in the functional range, it's the same. Slowly. Keep moving to your right. Keep moving. There. Stop. It's the same pathway. And that's more than 3 millimeters. So you only chew 3 millimeters laterally. Therefore, his protrusive and opening pathway are equal to his lateral border pathway. It's all the same pathway. Let's swing the chair around now and check the right side of it. See how it looks. Now, we have never recorded Bruce before. This is a brand new experience. So for him, can you see this now? There. Swinging right around there so you can see a good one. All right? I think this is still good. We can get a focus on it. There. Okay. Now we're going to do the lateral border movement. Slowly to your left. Stop right there. You see it's the same pathway. Keep going slowly. Stop. Same pathway. There. Stop. All the way it's the same pathway. Come back. So his protrusive pathway, his opening and closing pathway, and his lateral border pathways are all synonymous. They're all the same. Therefore, you can set the angulation of your articulator to that pathway, and it covers them all. This is diagnostic. Right here, we're making some diagnosis about his joints, and that tells me that the condyle head is fairly symmetrical. It's rounded. Otherwise, you wouldn't get the same pathways. It tells me that his axis is fairly constant to his mandible for these various movements. It also tells me that I did a pretty good job of locating the hinge axis, or we wouldn't get all the same lines. Now we'll go ahead here and measure the Bennett movement. How much side shift does he have? And what we do there, we're going to count forward 3 millimeters on the horizontal plane. If you can show the graph papers, that's great. Okay, right there. I'm going to count 1, 2, 3 on the horizontal line. Then I drop a vertical down and make a little mark right here where the 3 millimeter line forward would intersect the patient's pathway. Now it's farther than 3 millimeters when you go down the pathway, but I'm thinking just in the horizontal plane I want to count 1, 2, 3 millimeters forward and then drop a vertical line and make a little mark there. That will tell me how much looseness there is in the joints when he is canine to canine, tip to tip, because he's moved his mandible about 3 millimeters laterally when that happens, and this will have moved about 3 millimeters forward on this graph. And Olivia is going to do it on the other side. We measure the Bennett movement with this device only on the balancing side. We could measure on the working side, but it's very difficult to make the equipment work on the make it work on the working side, function I should say. It's a lot easier to record these Bennett movements on the balancing side. So once again then, we put the jaw back into terminal hinge position by putting our hand gently on the patient's jaw, and I push the stylus against the graph paper. If you can show my finger out here, back up just a little bit. No, the other finger. There. See, I'm pushing this against the graph paper. And with that finger against the graph paper, I then can tighten this screw right here. And then I take my thumb and push the Bennett ring, the sliding ring, over against the side of like this, right against the sidearm, like this. And then we release the screw like that. And now this thing is free to move. Let me go back again. Can you back it up just a tiny bit so they see the entire face? There, that's good. We have the mandible retruded when we start. We push the stylus against the tracing in the terminal hinge position. And with the stylus against the paper, I reach in here and tighten this little screw. Then I push the Bennett ring over tight against the sidearm, and the next step is to release the screw so that the sidearm will move. Now, if you back up just a tiny bit, I'll show you how I hold their head. I put my left hand, since I'm right-handed, I put my left hand on the cranium to support it. Then I have the patient move their jaw slowly, slowly to the left. Slowly, and I'll tell you when to stop, Bruce. Stop, right there. When he reaches that little line, I then push on his mandible. You'll have to back up just a little bit. See this farther back, way back. And you'll see me holding. Now, at that point, I push on the jaw really hard in a direction toward the working condyle, up in about a 45-degree angle, and the rings will separate right here, and that tells me how much looseness there is in the jaw. Now we'll turn him around so you can see this side shift develop, but I want to repeat it once more. Let me go back now, because this, once you learn it on one side, it's the same on the other. My hand is held on his head like this, my left hand. His jaw is retruded to terminal hinge position. At that point, I lock this screw right here with the stylus touching the paper in terminal hinge position. Then with the screw locked, I push this little white Bennett ring right over tight against the sidearm, right here, so right at this point. Now I release that screw, and that's very important to have that screw released now before we move his jaw. Now he's going to move his jaw left, and I'll tell him when to stop, so he goes slowly, stop right there. He's now reached that little Bennett checkpoint right there on the graph, right there above my finger, and at that point I'm going to push on his jaw like this, and we're going to turn him around a little bit, and you can see the Bennett develop here, how much when I induce it. So let's swing the chair back now, and what I'd like to have you do, Dr. Wacker, is we'll get his head down. I'm going to tip him as far forward as possible, like this, and I would like to have you zero in right here on this little scale. And you will see it start out at 0 with no Bennett, and then when I push on the angle of his mandible where the pterygoid muscles attach, right at the angle of the mandible, you'll see that ring separate from the sidearm, and you'll be able to read it on that millimeter scale. Now slide forward, slide back, way back, forward and back. One more time, stop. At that point, I push the stylus there, tight against the paper, and you'll see that there's no space. I think we're going to look almost straight on. Can you see it now? Chin down. And you'll see that the stylus is touching the sidearm. That's correct. You got a beauty. Now, he's going to slide to the left slowly, and I'll tell him when to stop. Slowly. You stop right there, a little more. Stop. You see about 1 millimeter of Bennett develop on his own, with his own muscles. Now watch how much it develops when I push on his jaw. Did you see the ring pop over? Okay, now that's what's going to happen when Bruce chews hard foods. When he chews yogurt, he's only going to get about 1 millimeter. When he chews hard food like meat or bread crusts, he's going to get 2 millimeters of Bennett movement. In other words, he has 2 millimeters of side shift, not 1, under function. Remember, function is really the most important thing of all. Shall we do it again to show it to you? All right, go back to centric. Stop, way back. Terminal hinge is the word. I push the stylus up, tight against the paper. The Bennett ring is touching the sidearm. Now slowly move to your left, and I'll tell you when to stop. Stop right there, hold it. You see about 1 millimeter of Bennett develop, or a little less. Now I'm going to push on his jaw like that. Boom, 2 millimeters. You do that 3 times and take the largest reading. Now relax. And it'll keep coming out consistently to that amount. How hard do you push on the mandible? We don't know. But you'll never push as hard as the patient's going to push when they're chewing. Now let's do the other side. I would use at least a 2 millimeter Bennett for him. Let's switch let's go this way. Can you see it over there now? So we can see how much Bennett there is. Let's go. That's right. I'll mark it. So on this side, what we did here to make him a little more comfortable, you see a little gauze pad. And sometimes these graft supports kind of rub the ear a little. Just slip a little gauze pad under them. So I'm going to count forward. Hold it right there. Oh, that's all right. 1, 2, 3, and come down here. Put my mark right here, like that. Now, if you want to do a new tracing, if you botch the tracing, you get a bunch of lines. It's easy. Just peel the paper off. Give me another one. We'll do some real nice, clean tracings for you. And it's very easy to do this. Or if you want to take multiple tracings, just peel the paper off and put a new one on. I just wanted to show you how this works, because sometimes you wonder, well, how did they get such nice, clean tracings? Well, we just took a new one. I'm going to have to locate the axis again. We've already done that. There we go. And now, Bruce, I'm going to take a tracing here in just a minute. Slide your jaw forward and back. Way forward, way back. Back, stop, way back. Hold it. Now I let the stylus up. Now protrude. Way out as far as you can go. Now come back. That's it. Do it one more time. Come back. Stop. I pull it away from the graft and take the elastic off. Now I'm going to count 3 millimeters forward and drop a vertical line from the horizontal. 1, 2, 3, and that will bring me right here to this point. And that's when his canines are tip to tip in his mouth, and that's where we're going to take the reading. Now slide back. Hold it. Now to start with, I push the stylus up against the terminal hinge position and lock this little screw. Then I take my thumb, push the Bennett ring over against the sidearm, then loosen the screw just like I did on the other side, and it's zeroed out. I like to work from the front of the patient if I'm doing it by myself, so I'll work this way. And this time I'm going to lean over the patient. I'm not sure I'll get the picture, I hope not. Now slide to the right slowly, slowly, slowly. Stop. Right, a little more. Stop, right there. Well, he doesn't show much Bennett movement there, so I'm going to induce like this, and boom. I get about 1.5 millimeters at least. Lock the screw. It's almost 2 millimeters, about 1 3/4 millimeters. Now I'm going to do it one more time, and I probably will push a little harder, and I probably can get up to 2 millimeters. So we'll loosen the screw again, go forward and back, way back, stop, hold it. Okay. And back to 0 again. Back in the typical boundaries like that so they can see the Bennett ring. Yeah, you can see it pretty well there, can't you? All right, now come slowly to the right, slowly, 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 slowly. Stop right there. And he only gets about 0.5 millimeter of Bennett back there until I push on his jaw. When I push on his jaw, I get about almost up to 2 millimeters. Yeah, I did. I made 2, almost made 2. So I at least give him a 2 millimeter Bennett per side. All right, now we're through the recording stage, and we're going to show you what to do next. What we like to do is mark the face width, because someone might forget. So I'll just take a pencil mark, and I'll rub it right here so that in case we lose our relationships, we can always come back to it. And if you'll just reach up and grab the Facebook right up here, Bruce, we're going to unbutton this thing like this. There, like that. Now very, very slowly pull it forward off your face like this. Let the patient do it. We don't want to pull their hair. If they do it, they won't pull their hair. If we do it, we might catch their hair. All right, now what I've done here is put a little pencil mark right here so that if inadvertently somebody loosens this screw and you lose your lateral relationships, you don't know where it is, you can come right back to the pencil marks right there and tighten it like this, and you know that you'll have the face bow. Now at this point, don't do anything with this face bow. Set it aside and go ahead and finish marking your hinge axis on a patient and removing the clutch. If we are going to mark the axis, we alcohol the skin first. We never tattoo our patients here. You know, tattooing is for those people in the Navy down in San Diego, and we never tattoo patients. We mark the skin with a minute microscopic point or spot that we hope we can find later with a magnifying glass. That's the way I talk to the patients. I never mention such things as tattooing. But when you mark the axis, be sure that you alcohol the skin very well. Clean it very good, like this. And the patient must be sitting upright. Now, I have my lead stylus on, and but you don't have yours. We're going to mark it with the old-fashioned way. All right, we'll take off the writing lead then. Patient should be sitting upright. Can you back away from this? Way back. And the face should be expressionless. And I know it's kind of cool, because when you're laughing, the skin is moving, and sometimes it can move as much as 4 or 5 millimeters on some people. So we like to have no jokes being told at this time. Anyway, with the skin now being cleaned with alcohol, we then rub the lead pencil, the soft pencil, over the steel pins like this. And Bruce, you can slide your lower jaw forward and slide back, forward and back, forward and back. Stop. And we then go up and touch the skin. And the way we do this, pull those Bennett rings way back. If you can't reach the skin, take the Bennett ring completely off and just use the steel pin by itself. Like this. Now come forward, slide back. Forward and back. Way back, stop. You have to come back at least 3 times to the same point to know that the skin is static. Slide forward, slide back, slide forward, slide back, stop. Okay? Can you see that yet, or shall I turn him a little bit so you can see it repeating? Maybe you can zero in on that now so they can see it. All right, Bruce, slide forward, slide back, slide forward, slide back. And you notice I don't even push on his chin. I just have my finger lightly touching it. Can you see the spot? Now watch where the steel pin goes over and touches. Does that show? Okay. So we're repeating. That means the skin is static over the joints. If you have the head in any other position, it might not be repeatable. So this is the most repeatable position to mark the axis for future face bow transfer. How's your side? Is it good? Okay. It's very, very close to the tragus there. Okay. Okay. Now we can take this off. We remove the styli. We don't have to mark the 3rd point of reference because our equipment is all designed to register against the nasion, so there's no need to mark the 3rd point in the nose. And the next step then is to loosen the sidearms, take them completely off. And Olivia will remove the other side. Be sure and loosen this. Now we don't mark the axis right away. I'm going to take off the clamp and get him out of the clutch here right away. We loosen these 2 screws and then twist and pull the rod laterally to take the clamp and the rod off. Do not put these clamps or rods in ultrasonic or cold sterilizing solution. Alcohol sterilizing is the only way, because Those other solutions will eat the metal. Those are aluminum. And then we have the gold handle clutch remover, which looks very much like the Sears Roebuck screwdriver, but we don't use screwdrivers on our patients. So the dental assistant hands me the gold handle clutch remover. I hold the lip down. If you noticed where my index finger is, it's right here against his lower lip to keep it down. There's a pry slot right in here. It's a vertical slot that you can put this gold handle clutch remover in. You twist it like this, right and left like that, and then this glitter comes off, and we can fracture the clutch apart like this and lift it out. And if it's still on his teeth, he can bite down and grind your teeth, and that will break it usually. Now Bruce has rinsed his mouth out. You can lay your head right back there, Bruce. And once that we have this little point here on the skin, this little spot, which is the lead from just an ordinary lead pencil, the head can be in any direction. It does not have to be, the patient doesn't have to be sitting straight up when we mark the axis. With the women, we use a little pink dye, which is, oh, sorry about this. We'll drop him back down there a little bit. There we go. All right. With the women, we use the pink dye, which comes with the kit, and with the men, I usually use the India ink, and we use a 27 gauge infiltration needle. So we'll show you how this works here. Let me hold it right here. The infiltration needle. Just take it out like that, and just take the India ink and let the capillary action run down. Take the dye down the tube. See, that's 27 gauge, so that's all you have to do. And then coming over to the skin, we stretch the skin like this, and we just go into the outer layer of the skin like that, and just put a little spot there. Now we'll hold this, and I'll take the gauze, wipe it off, and you'll see a tiny little spot. That spot will fade. Can you still see it? It looks like a little whisker. Can you see it at all? Can you get it? It's right there at the end of my finger. We can see it with our glasses, but yes, you can see it there. Now, in a few days, that will not be as bright as it is today. It will fade a little bit, and hopefully you can see that spot. But sometimes, if you want to, you can take a ruler and measure from the canthus of the eye back to the tragus, and then draw a vertical line down and make a little graph and put it on your patient's chart, and you can find that even if you didn't mark it like I did permanently, you can find it within a millimeter easily if you just take a ruler and measure some coordinates from the canthus of the eye back to the tragus of the ear, the superior border of the tragus right here, and then drop a vertical line down, measure it in millimeters, and you can go back there and find the area, and you can get very, very close. Now let's mark this side. Now this one is located very, very close to the tragus. I'm just going to prick it right there. Sometimes the marks are right on the tragus of the ear. That's why you have to cover the tragus of the ear when you are locating the hinge axis. Okay, I think we'll take a break and then we'll be right back. We're going to find the orbital axis reference plane, and what we do here is to take the articulator, and there's a support post. We pull off this plastic cap and slide the face bow down over it, like so. There we go. All right, and then lock it there, like this. And we're just using the articulator as a support. I can loosen this and I can raise it up here in the air like this. We have two little clamps like this, and we put the screw on the inside against the metal. Be sure these clamps are placed well below the tracing. I'll do it on this side over here. The clamp is placed well below the tracing, way down. Like this to start with. This is called a reference plane tool for getting the orbital axis reference plane. And what we do there is to come in from this direction, lift this up and straddle the draft papers like that. And then we have a little clamp, and I'm not sure you can see this. I'll get down here, where there's a little dimple there in the front, which I pointed out to you, and we put a little pointer into that dimple so it will pivot there. And there's a spring back here from the back that holds it there and lets it pivot. Now remember that your plane of reference is not the nasion, it's 7/8 of an inch below the nasion, so that point right here and the two hinge points back here all have to be joined together on one plane, and I'm going to do that now. So I raise the clamp up until I see the terminal hinge position showing up there. I raise this side up and I'll see the terminal hinge position right here. And now it's pivoting around the third point of reference right out here. Come back and check this side once more so I can see about 1/2 millimeter of the terminal hinge position just showing. Can you zero in on that now and show that? Okay, you can see it. All right, now also if you back up, can you see that this plane is not parallel to the head frame? That means that the axis is much lower on the left side of his head than it is on the right side. That's one explanation. The other explanation is maybe one ear is higher than the other. So we are not interested in the anatomy right now. We're interested in the dynamics. So we must join the two hinge axis points to the third point of reference out here and put it all on one plane. And somebody may ask, well, couldn't you do that with a ruler? Yes, if the hinge axis went straight through the head on all patients and intersected these plates at exactly at right angles, you could use a ruler because you're dealing with only two planes of space. Well, when you're dealing with a tilt like this, you can't use a ruler anymore because you have to join 3 points in space, and you're dealing with 3 dimensions. So that's why this tool is made like it is, so that you can join 3 points and allow for the tilt of the axis when you draw your reference line on here. A ruler concept is only good if the axis went straight through the head like this and intersected these plates at exactly right angles, but not when it tilts. So now we take a sharp Panadent pencil. Be sure that it says Panadent on it, it won't write otherwise, and then you scribe your plane of reference line like that. Can you see this in the picture? Come to this side over here, and we'll do the same thing. And we can take the clamps off, and we have joined all 3 points, 2 hinge points, and the third point of reference called the orbital point. And we can now peel our draft papers off like this. Do it slowly. Don't rip them off because you want to save these as database records. We can go over here to our board, and I can paste them up there. Do we have the something to light, please? I'll put one right here. Now, ordinarily, these will go on the patient's chart at this time. I think maybe you can see this with the camera. I know you stand beside it. Let's say this is on the patient's chart like this, and we now have the see-through protractor, which has the printed pathways on it. All right, now there's the pathway there. Be sure they're not upside down like this. If they look like they're reading Russian, you're going to get the right side and the left side mixed up, confused. So it must be English. I'm going to say Panadent. And now we look directly down, and I'll have to do this in front of you like this, and I rotate the protractor until I can cover the functional range of movement of the patient. And I'm going to read this one at 8. For this side, and I take my pencil and put angle equals 8, and on this side I'll go leave it at 6. Angular here is 6 equals 6. Now we know the Bennett point right here where I took the check bite, the B point equaled 2 on both sides, didn't it? 2 millimeters. And this B point right here we just put B equals 2 millimeters. And we know the angular setting now. One thing for sure, when you're reading these things, never set the articulator steeper than that pathway. It is permissible to have the pathway of the articulator, now that's this curved path right in your protractor, to be above the patient's line, but never below the patient's line. Because if you set it below the patient's line, if there's a question, like if you see two lines or something, always read the highest line, because you will have interferences. If you set your articulator steeper than the patient's pathway, then it's possible that you'll have interferences. That's what creates a lot of interferences. So anyway, just remember that you can set it equal to the patient's line or slightly above it. When we're taking these readings here, we set it right on the patient's line. But when I give the rotational settings to the technician, I very often will raise it to a number and flatten it out, rather than to have him wax the teeth too close, because technicians trust the articulator implicitly, and I know that there will be flexions and compressions, and so I want a little more clearance, so I kind of control the laboratory that way. But on these papers, we put the actual readings we get. For instance, we got 2 millimeters of Bennett movement. Now, in actuality, in the articulator, I would probably go to 2.5 millimeters, because I know there will be flexions in the jaw. And there might be things happening in vivo that don't happen in vitro, and what we did up there wasn't, quotes, in vivo. It's a little less, quite a bit less. You put a lot more pressure, and flexions will take place a lot more when you're chewing food than when I was pushing on his jaw.